Hi, my name's Toni Storm. I'm a surgical oncologist with Compass Oncology. I specialize in breast cancer care, which I find a great honor, and I'm very happy to be able to talk with everyone about some of the issues that I think often get lost, in translation, and that is, where do our patients fit into what we're doing, and what is their role? And so I think to start with, we have to have a nice quintessential Portland cat, because anybody can look cool, but awesome definitely takes practice. So breast cancer is one of those diseases that has been really enmeshed in a debate forever, as long as it's been around. And we know that what really makes breast cancer deadly is it's when it becomes systemic, when it goes to other parts of the body. And the way to address systemic disease is not with surgery, it's with systemic treatments like chemotherapy, and to understand biology. So if we understand that, what is exactly the issue with surgery, and kind of where do we go from here, and how does surgery help our patients? So I think we need to understand that, again, going back, as long as there's been written word, we know that people have talked about breast cancer. Hippocrates talked about it in 460 BC as an excess of black bile. And the ancient Greeks talked about it, they have it on ancient writings, as, again, this bulging tumor that had no cure. Early groups favored cauterization. They'd literally take a great big branding iron and just put it right on the tumor to try to treat it. The Romans were pretty fancy, they did excision. And then we had, especially with the French and Gerard Tabor in 1721, the breast guillotine. And that's because we didn't have anesthesia yet, and it hurt. So we wanted to do whatever we did fast. Then we came up with anesthesia, and along came William Halsted, who actually really was a brilliant man. And he thought, as people did at the time, that breast cancer started from a single spot and then moved out in a kind of ever-progressing ring, advancing. And so the more aggressive you were in terms of surgically treating that disease locally or where it started, the better the response would be. This held for about 100 years. This is an example of one of the old texts showing literally how what was called the radical mastectomy or the Halsted mastectomy was performed. They took the breast, they took the pectoralis major, the pectoralis minor, and what we call level 1, 2, and 3 lymph nodes. And women were left with a lot of morbidity or a lot of, as you can see, problems. They had cosmetic defect, they had shoulder weakness. And so along came a pretty incredible guy, Bernie Fisher. And in 1967, he became the first chair of the National Surgical Adjuvant Breast and Bowel Project program. And he said, wait a second, what about us using some basic science and some actual prospective studies and kind of look at how can we treat this disease? And so he came up with two big landmark studies. The first was the NSABP B04 trial. And this was a trial that looked at comparing a radical mastectomy with a simple mastectomy or a simple mastectomy followed by radiation. And what he found was an equal survival benefit, regardless of which type. This was huge. In fact, it was such a big deal that he was criticized amongst his colleagues here in the United States. Had a very hard time initially trying to accrue patients with his colleagues here, and the Canadians were a big part of helping him to accrue or to obtain those patients for the studies, because women lined up. They wanted something else. They didn't want that radical mastectomy, and they said, we want some choice. We want to be part of our care, and we don't want to look like that, and we don't want to feel like that. And so all of a sudden they started to accrue patients like crazy. With that came the next trial, which is the B06 trial. And in this one they looked at showing an equivalent survival with lumpectomy and radiation as with a mastectomy. This was a complete game changer. This is when we really started to first add adjuvant radiation. So now this trial came out, the study was run from 1976 to 1984. So it came out in 84. But we didn't yet start to see change. So why? Why is change so hard? She's now 11 and she still thinks change is really, really hard. as do many of us. So I think that part of it was we still had a bit of an understanding that thought that really this is the way we had to take care of this disease, that this was a disease that was progressing out, and that local recurrence was important. And we knew that local recurrence was important because we have studies that show that an in-breast recurrence is much higher in a patient who, for instance, has positive margins. And that's regardless of if it's invasive or pre-invasive, what we call in situ disease. And so they started to say, okay, well, what other kinds of things can we do for this radiation to try to look at this? And what other factors might be involved in terms of like biology, et cetera? So in 1993, which is not that long ago, we had articles starting to come out because there were still so many people still doing mastectomies on everyone with breast cancer, regardless, that this was written in the New York Times. I am puzzled as to what combination of educational prejudice, financial, and historical issues have failed to get lumpectomies going. Most women do not choose mastectomies, yet they have them anyway. The problem is the doctors. Okay, so the issue is we're slow to change, not because people, I think, were trying to not give people an option. They were trying to look at what's best. What is the science? How do we do this right? And it took us a while. It took time for Bernie Fisher to show us with these studies this data and for it to be accepted. Remember, initially he was villainized. So it wasn't until this study in 1995 that we started seeing papers saying that this is the way that we should treat this disease, that this is the standard of care, and that we can show that breast conservation or a lumpectomy plus radiation is a viable option. So now, again, look at that date. I think it's very significant. So now I want to move into the fact that I feel that the pendulum is swinging the other way. And why do I say that? Well, because now we have consensus statements coming out from societies like my society, the American Society of Breast Surgeons, which was published in 2016, basically stating that the majority of women will obtain no oncologic benefit from a contralateral prophylactic mastectomy. That's what a CPM is. And therefore, CPM should be discouraged in average risk patients with unilateral cancer. So the only thing that they were looking at is there a survival benefit? Now, if we go back to what Bernie Fisher was trying to do, he was looking at more than is there a survival benefit? Because if there was nothing but a survival benefit, if we had an equivalence with doing a radical mastectomy, why change anything? We changed things because we were involving our patients in what options can we give them, and we were trying to continue to learn and be better at our craft and what we do. So the NCCN has guidelines that also recommend that we not perform a contralateral prophylactic mastectomy for a unilateral cancer, and that the only time that we really should perform a contralateral mastectomy is in patients who carry a gene. We see this repeatedly from multiple societies showing that their recommendation is that we should not perform a contralateral prophylactic mastectomy. So in the United Kingdom, you can't even have a contralateral prophylactic mastectomy if you choose. You have to be a gene carrier. That is the only exception. They will not perform it in the state's government system. So if we're thinking about things and we're thinking about cost as well, I think that the cost of radiation is significant, and we have studies of that over a simple mastectomy, but we still want to offer that to women, and we want to offer it to them because we want to be able to involve patients in their choice. And so if we think about unilateral mastectomy, we know that there's definitely a role for that. There's no doubt, especially if somebody has a large tumor and we're going to have an unacceptable cosmetic result, if there's a local recurrence, meaning that a patient had breast cancer before and now it's back, so they failed their conservative treatment. If they're very, very young and we think that they're at extremely high risk, there are reasons. What about the psychosocial outcomes, and what do we think about the decision for a CPM? And what have we found looking at some different studies? So one study in particular looked at women between 1970 and 1999 and showed that survival, that this particular survey was mailed to women. And what they found was that with CPMs after breast cancer diagnosis, that these women, 519 having CPMs and 61 were randomly chosen that had a unilateral, that they were actually quite happy. They looked at several markers. They looked at contentment with quality of life, body imaging, sexual satisfaction, breast cancer concerns, depression, and health perceptions. And they found that women who had elected to undergo a CPM, or a contralateral prophylactic mastectomy, were very satisfied with their decision 86.5% of the time, which is quite good. And these again are those factors. So when they began to break it down even further into just high quality of life, they found that women who had a unilateral mastectomy were almost equally happy as those who had chose to have a bilateral or a contralateral prophylactic at the same time. And so they said, what's going on? Why do we see this? What does this mean? And where do we go from here? And does a woman who has a unilateral mastectomy, does she have a choice to perhaps say, whether she's reconstructed or not, I don't want to have this asymmetry. I don't want to wear a prosthetic, or I would choose to be flat. Is this her right? And I show this picture because I want to make sure that everyone understands that I'm a big fan of breast conservation, that I think it can look beautiful and we can have great outcomes, especially with oncoplastic approaches, which I also feel should be offered to women. I think that they should be educated about what their options are. But when we have surgeries that are done perhaps in a non-oncologic approach and with adjuvant radiation, the cosmetic defect can be significant. So the survival may be excellent for all of these women, but the impact of a cosmetic defect is significant. Now, could they have had an oncoplastic approach and had a better outcome? And I think that the answer is yes, they could have. And I think that they deserve better. This is an example really more of what can happen sometimes with radiation that we don't completely understand. And that is when some women have significant shrinkage, where the breast becomes much, much smaller. There are some new studies coming out helping us to try to identify which patients are more prone to have this. But this is something that is not always evident to us either. So what do patients want? And what do they think about all of this? What are they telling us? What have we learned by working with them? And I think that this graph is very important because what it's showing is that we see an increase in mastectomies. Rather, we're just talking about a unilateral, a bilateral, with reconstruction, without reconstruction. If we look even further, we see an increase in mastectomies and contralateral mastectomies, unilateral and bilateral, regardless of the stage. So women with early stage breast cancers are also picking it. And what this shows is that we also see this trend regardless of age. So very old women are also choosing to have CPMs, and again, they're often not reconstructed. So what this particular article showed, and this was in the Breast Journal in 2016, and it looked at the psychological and sexual well-being following nipple-sparing mastectomies, and did the breast Q through Sloan Kettering. And what they found was that women who had nipple-sparing mastectomies, for the most part, were happier than women who did not have nipple-sparing mastectomies. And then I think it's also important to keep in mind some other data, especially in young women, showing that you have a higher local recurrence if you're very young, which makes sense. You have more years to have an event occur. But with that recurrence, there is actually a higher mortality, which we don't see as much in older women who have a recurrence. So I think that that's also very important. We need to look at that when we put all of these pieces together. So when a younger woman is treated with breast conservation and radiation, she has about a 13% higher risk for local recurrence over 20 years versus if she had a mastectomy and no radiation. We know that with local recurrence in these women, that about doubles their risk of distant disease or metastasis. And metastasis is the scary component of the disease. And the risk of death is about 2/3 higher for patients in this category that choose to undergo breast conservation, which is very significant. What this graph shows, and this is kind of where I'm heading with this whole talk, and I'm leading you guys intentionally a little bit into a place where what I really want to take home is what we're seeing here. So in this graph, what we see is that when patients make the choice to have a contralateral mastectomy or to have a mastectomy in general, they will choose mastectomy. When doctors make the decision, they will choose breast conservation. And when we make the decision together, you see this middle section, and you see that we have quite a bit of balance. And so what this shows us is that women are smart and that they should be, I believe, involved in their care. Because when we involve women in their care, what we start to find is that it's less about what your choice was and more about that you were able to have that choice. In other words, we have data. This is a study showing early stage breast cancer costs and some of the complications, which I think is important because you can see that where you're going to have the least risk is actually mastectomy without reconstruction. Where you're going to have the most risk is mastectomy with reconstruction, which I also think is somewhat interesting. But what we've learned by looking at these studies and looking at these outcomes and even looking at these costs, because one of the concerns is the cost of mastectomy. And I think that the answer is not simple, but the answer lies in the patient. Because if we as physicians take the time to educate our patients and to make sure that they understand what their options are so that they make a choice not out of fear, but out of choice and out of being educated, then they can pick something that they will be most happy with. And we have many studies now starting to show that it's really less about what procedure a woman had, lumpectomy with radiation, mastectomy, or mastectomy with reconstruction, and more about were they involved in their care? Were they involved in the choices they made? And when they are, regardless of what that choice is, unilateral, bilateral, they are happier. We see that they have a higher satisfaction. And we have multiple studies starting to show this. For instance, this particular study, which was put out by Sunny Mitchell, was done to show also that women often get fearful. And when they're fearful, they think that they need to do something right away. And they'll make a decision that may be not the ideal decision because they're rushing themselves. But that, in fact, we don't need to rush. And that when women have more time, they may choose breast conservation, they may choose mastectomy. But they'll make a choice that's better for them. And we also have learned with these studies and other studies that we can't just expect our patients to go out and read about it. We as providers need to be there to educate them about these options so that they understand, for instance, that there's no survival benefit in a mastectomy. So you don't have to have a mastectomy. So if I'll ask a woman if I feel that she's an excellent candidate for breast conservation and she chooses a mastectomy, I'll say, why are you choosing the mastectomy? If the answer is recurrence and fear, I'm going to talk to her a lot because that's not really the ideal reason, right, to be making that decision. But if the decision is that I've had multiple biopsies over the years, I don't want mammograms, and I don't want to do additional radiation or whatever, if it's thoughtful, then I feel that we should be able to respect their choice just as much as we respected the women who said, I don't want to have a big crater on my chest with a radical mastectomy, or I don't want to just have a mastectomy without the option of reconstruction. We've gone from doing mastectomies where we had delayed reconstruction and never nipple sparing. Now we do nipple sparing and we do beautiful skin sparing mastectomies on larger women, and they're extremely happy. And it doesn't matter if it's unilateral or bilateral. And even when we do a lumpectomy, I think it's incumbent upon us to do the best job we can to leave those people, those women, feeling whole. And the way we do that is by doing the best surgery we can. So if a woman's going to have a lumpectomy, she should have an oncoplastic approach, which means that we leave the breast looking as nice as we possibly can, so that every day when she gets out of the shower, she's not reminded that she had breast cancer. she's able to start moving on. These are a big part of the things that lead to the depression and anxiety that we so often see associated years later with a woman who's undergone a breast cancer diagnosis. So in the end, while I kind of led you guys down a road to make it sound like perhaps I think that everybody should have mastectomies, I certainly do not. I think that lumpectomy with radiation is a wonderful choice, and I think it is the right choice for most women. But what I think in the end, most importantly, is that we owe it to our patients to give them a choice, to allow them to understand what the issues are and to be able to partner with us in their care so that they can maximize their outcomes and feel that they're part of their care. And then their satisfaction goes up and their depression goes down. If you have any questions, if you'd like more information, please come visit us at compassoncology.com or feel free to call or come in and visit us. Thank you very much.